Good evening and thank you everyone for joining us today. I, Amit Saxena, along with my colleague Dr. Deepika Chabra from Medical Services and Mr. Om Prakash Sharma, Zonal Sales Manager, West Zone NAARI Division of Jagsonpal Pharmaceuticals, are pleased to welcome you all to this webinar to interact with our experts on endometriosis and infertility management update. This is knowledge sharing initiative of NAARI Division of Jagsonpal Pharmaceuticals, makers of EndoReg, 2 milligram tablets of Dienogest. We would like to express our gratitude and warm and hearty welcome to all the attendees, our esteemed experts. We kindly request you to post your questions, explanations, suggestions via text in Q&A box or chat box. This webinar is streaming live on Facebook and the link will be shared in the chat for the circulation. We will be sharing the YouTube link for you to watch in the future. Now I requesting Dr. Deepika Chabra to kindly introduce our chairperson, expert commentators and speaker.
Thank you, Mr. Amit Saxena. So we are very pleased to have with us the experts here today. First of all, I'd like to introduce the chairperson for the session today. We have Dr. Sumita Verma. She is the founding secretary, Faizabad ObGyn Society from 2009 till 2020. She is at present the director and consultant, Deva Memorial Hospital of Advanced Endoscopy, and she has special interest in imaging and high-risk obstetrics, minimal invasive surgery. Welcome to you, ma'am. And now I would request Dr. Sumita Verma, ma'am, to introduce both the expert and the speaker.
Good evening, everyone. Welcome to this webinar on endometriosis and infertility management update. As we all know, endometriosis is a very distressing common problem affecting women in the reproductive age group. And 6 to 8% of people with women with infertile are likely to have endometriosis. And infertile endometriosis patients are more likely to have endometriosis. Today, we are very lucky that we have two stalwarts with us, the chairpersons of the Infertility Committee and chairperson of the Endometriosis Committee. I would like to introduce Dr. Asha Rao. She is the chairperson, Endometriosis Committee, FOGSI 2020-23. She has more than 25 years of experience in ART and is the director of Rao Hospital and C.A.R.E. Coimbatore. She is director for postdoctoral fellowship program in reproductive medicine and endogynecology and affiliated to Tamil Nadu Dr. MGR Medical University. She is past president Coimbatore ObGyn Society, organizing chairperson Endo Insight, organizing chairperson Yuva FOGSI, IAGE, and the 8th National C.A.R.E. She has trained us London and Brussels under world-renowned experts, and she has delivered the first FOGSI baby of Coimbatore in 1998 and first vitrification baby of 2008. Welcome, ma'am. She will be giving and summing up the talk and giving us the important take-home messages. Our speaker for today is Dr. Kundan Ingale. He is the chairperson of the Infertility Committee, FOGSI 2020 and 23. She has the award for the best research in C.A.R.E 2019, C.A.R.E 2018, and FOGSI 2019. He is director of Nirmiti Clinic Center for Assisted Reproduction and Endoscopy, Pune. His general secretary, FOGS 1920, founder treasurer Maharashtra C.A.R.E 11 to 14, founder member Pune Gynae endoscopic surgeon. He has presented first time research at 6th COG World Congress at Vietnam on use of CGCF subcutaneously for thin endometrium. Welcome, sir. We are waiting to hear your update.
Thank you very much, Dr. Sumita, for those kind words of introduction. At the onset, I will like to place a vote of thanks to the Jagsonpal team, Dr. Deepika Chabra and Mr. Om Prakash and Mr. Amit Saxena also, for inviting me for such a August gathering. That's a webinar on endometriosis and infertility. Thank you very much. And it's one of my very favorite topic, and love to speak on endometriosis all the time. Uh, it's a privilege, Madam Dr. Sumita, to have you as the chairperson. And with your permission, I will like to start my presentation. And again, it's a grand welcome to Dr. Asha Rao, my co-chairperson in with FOGSI. She's a endometriosis committee chairperson, doing excellent work in endometriosis, and together we have done so many programs. So let me begin with saying that what is exactly is the endometriosis is basically it's a presence of endometrial like tissue outside the uterus, which induces a chronic inflammatory reaction. And this is what we have to understand today, that it's a inflammatory reaction, and it is every time she bleeds from those abnormal implants, she does keep on having inflammatory response in that area. And that is very important, that all the symptoms, not only infertility related, but it is mainly the gynecological symptoms, that is all dysmenorrhea, dyspareunia, all are related to this inflammatory reaction. We know that Karl Rokitansky is a discoverer of endometriosis, and now which normally we get 2 to 10% of incidence of endometriosis in a general female population. But when a patient comes to you chronic with a chronic pelvic pain, this group of patients we will come across almost 70 to 89% incidence of endometriosis, we will find it out. If you look at the classification system, the revised ASRM classification is the one which is widely accepted as the one of the best way to grade the disease. And depending on the grades, we will have a kind of prognosis assessment, as well as we'll be able to decide the management strategies, that how should we manage these stages. Now, these staging systems are based on what kind of appearance these lesions have, what kind of size they have, and what kind of depth of penetration into the deeper tissue, that is deep infiltrating endometriosis. That is also helps out you to stage the disease. Now, also the presence, extent, and type of lesions, means whether they are red lesions, white lesions, whether they are black lesions, whether they are fibrotic lesions, and also the adnexal adhesions and degree of cul-de-sac obliteration. So all these points are considered to grade the disease. Now, why do we grade? The grading help us to understand the severity of the disease. And not only that, because of this grading, which has been used for a research for different strategies of management of endometriosis, we have certain guidelines according to this stage. Let me simplify rather than giving you this score, which is seen in the slide. I always feel that when you come across, say, not more than 5 implants, you always call it as a minimal disease. Now, typically in minimal disease, you will see up to 5 implants all over pelvic peritoneum, and it's a very minimal disease where no ovaries are involved. I mean, no endometrioma, or probably no pouch of Douglas obliteration. The moment you say mild disease, where you do have a peritoneal disease, that is you have more than 5 implants, and you have, say, tubo-ovarian adhesions or ovarian peritoneal adhesions, or probably even a single unilateral endometrioma of a smaller size can come into a mild disease. When it comes to moderate disease, remember, we say moderate disease, usually it is bilateral involvement of adnexa. So you may have disease presence on both the sides of adnexa, in the form of maybe endometrioma, in the form of maybe extraovarian endometriosis, or probably some implants into the ovarian fossa, also leading to ovarian adhesions. So moderate disease is that, but even partial obliteration of pouch of Douglas comes into moderate disease. So if you look at because this grading comes when you do a laparoscopy, and when you look at the pelvic area through laparoscope, then you will be able to stage this disease. So instead of scoring, I always felt that this is very simplified, practical way of staging the disease. When it comes to severe, obviously bilateral disease has to be there, but the most important severe disease is where the pouch of Douglas is completely obliterated, or any extra pelvic, extra uterine involvement, bladder, bowel, ureter, all this, they come into a severe disease. Now, it does not reflect the intensity of endometriosis associated symptoms, because we have seen that even a frozen pelvis due to severe endometriosis, patient come with asymptomatic status. So it's not actually the disease process or a staging will help you to say that in the symptoms severity is also going to increase. Underestimating the most active forms of this disease and does not facilitate tracking the likely natural progression of the disease. So simply the staging is to assess the prognosis and to decide management strategy. Otherwise, no other conclusion can be drawn from this. Now, what are those mechanisms? Because I'm discussing infertility related, endometriosis related infertility. So what are those mechanisms? So one is a minimal to mild disease. So in this, particularly the infertility is seen because of there are changes in the peritoneal fluid. Now, what are those kind of changes? So all abnormal cytokines presence in the peritoneal fluid in the pelvic cavity that is going to alter the pelvic architecture. Not only that, we do see that even in a minimal to mild disease, we do have a abnormal myometrial peristalsis. We do see because of abnormal cytokines like interleukin C, decreased VGF, we see abnormal follicular and embryo quality. And also we do see ovulation disorders like anovulation, hyperprolactinemia, premature follicle rupture, or luteinized unruptured follicle, luteal phase defect, and there are other immunological abnormalities. So all these things collectively interfere into fertility, and minimal to mild disease is also associated with infertility. Now, obviously, once the disease process progresses from stage 1 to stage 2 to or stage 3 to stage 4, that is moderate to severe, you have a lot of adhesions between reproductive organs. So adhesions which actually causing a distortion of pelvic architecture. The most important, when I say distortion, it is the tubo-ovarian relation which is distorted. So commonly, this is what is the major cause in endometriosis when it is pelvic adhesions or moderate to severe disease plays a role in infertility. Also, you sometimes we do see that if the femoral end is blocked, a patient do come with a hydrosalpinx, or if the femoral end is adherent to the peritoneal surface or endometriotic implant, it blocks that opening and patient do come with a hydrosalpinx. Very rarely you come across tubal involvement in endometriosis like tubal narrowing or constrictions or even proximal tubal occlusion. In fact, that is something which is very rare scenario what we see against the disease process. Now, if you classify the endometriotic lesions, there are 3 important lesions. These are important because our management strategies, our disease process, as I said, is all depends on these lesions types. So one is a superficial endometriotic lesions where you will see endometriotic implant present on peritoneal or ovarian surfaces. Then we may see a isolated endometriotic cyst or ovarian endometrioma where probably you may get it isolated, means only endometriotic cyst without any peritoneal involvement, or you may have all the other peritoneal involvement. So both ways you can have endometrioma with other disease, other involvement. Now, deep infiltrating lesions are the lesions, particularly they are not superficial, but they are invading the deeper tissue and going into the depth of the pelvic peritoneum or into the surrounding organs like bladder or rectal wall, where it is difficult for us laparoscopically to assess the depth of that lesion or depth of invasion of that lesion. And that's why DIE is something which you sometimes we cannot really assess that how much deeper is the disease present into the pelvic peritoneum. So it's a little confusing lesions, I always felt. When it comes to diagnosis, now we have understood few things. We have understood the endometriosis, we have understood the mechanism of infertility. Now let's come to the diagnosis. Now, regarding a diagnosis, there were a lot of changes into the recent ASHRAE guidelines. Now, if you look at the classical way is the clinical examination. And the most important clinical examination is a vaginal examination and should be considered to identify deep nodules or presence of endometriomas in patients of suspected endometriosis. But unfortunately, now with the ultrasound probe in our hand, sometimes we have really forgotten the skills of diagnosing nodules and endometrioma. So the diagnostic accuracy has really gone down. And when it comes to adolescent, instead of per vaginal, rectal examination can be very, very helpful for reaching that diagnosis of endometriosis. Now, in a deep endometriosis, you will see or you will feel painful induration or nodules of rectovaginal or visible vaginal nodules in the posterior vaginal forming. So typically that rectovaginal nodules, if you do a bimanual examination, that is fingers in vagina and per rectal examination, and you palpate between your two fingers the nodules of deeper endometriosis. About ovarian endometrium, typically you will see that bogginess in the fornices with adnexal masses, and if clinical examination is normal, remember you cannot 100% surely rule out endometriosis, because you may have no evidence on clinical examinations, but still patient has endometriosis. Now, in women with suspected endometriosis, further diagnostic steps, including imaging, should be considered even if the clinical examination is normal, because use of imaging like ultrasound or MRI in diagnostic workup, they need to be aware that negative finding does not exclude endometriosis. Same applies here for imaging also, like what we discuss in clinical examination. So particularly superficial peritoneal disease may not be picked up by ultrasound and MRI. And they also at the same time, remember the guidelines are very clear. There are no role of measurement of biomarkers in endometrial tissue or presence of these biomarkers in blood, menstrual blood, or to diagnose endometriosis. Another very common investigation, we used to always say that it is a gold standard investigation, is a laparoscopy. And now 2022 ESHRE guidelines have been clearly documented with evidence in the literature that it is no longer the diagnostic gold standard, and now only recommended in patients with a negative imaging results and where the empirical treatment was unsuccessful or inappropriate. Then in that case, laparoscopy plays a role. So remember, it's if you suspect, don't go for laparoscopy. Still, you can use clinical examination. You can go ahead with imaging like ultrasound and MRI, but instead of putting an invasive test like laparoscopy. And laparoscopic identification of endometriotic lesions is confirmed by histology, although remember again, for histology, negative histology does not entirely rule out the disease. So as far as possible, take a biopsy when you are doing laparoscopy for whatever indication I mentioned, and take a biopsy and confirm that there is a presence of endometriosis. Now, when it comes to diagnosis, now these are the few things which we need to understand, that they are classical signs, and that's why I got these few videos for you, where in these videos they are beautifully demonstrated, and it really helps in getting a lot of information about endometriosis and its affection into the fertility. Now, in this particular first video, as you can see, there is a ground glass appearance behind the uterus. Can you see this cystic lesion, which has got a ground glass appearance, and it is just behind the uterus? And that's a typical look of endometriotic scene. That look or that appearance is not seen in any other kind of lesions. So you don't have a differential diagnosis. Once you see this kind of picture, it is diagnostic of endometriosis. Now this test, which is, you can see the probe is moving to and fro, but can you see that the lesion is not moving away from the uterus? It is still adherent even with the to and fro movements of probe. That indicates that that's an ovarian endometrium which is adherent to the posterior surface of endometriosis. So ultrasound does help to understand. This is the typically you have to understand that when I'm moving this probe, look at the other surface, opposite surface of ovary, where it is moving in an opposite direction in of the movement of ovarian direction. So this is how you can be very sure that how whether ovaries are adherent or not adherent. Like look at in this, you can see a bilateral endometrium, that's the uterus in front. As I'm moving and pushing the uterus, the lesions are actually moving in the same direction where the uterus is moving. And as you can see, even the ovaries are moving together. So that indicates that even the both ovaries are adherent to each other, along with that adhesions into the posterior surface of uterus. Now, if I go further, probably maybe next slide. Yeah, in these videos, I got it for understanding the abnormal sliding sign. Can you look at this video? When I'm moving the probe and moving the uterus, see the uterus is going to the right and the opposite surface is going to the left. So that is a normal sliding sign. But when you see that the direction which the uterus is moving, and same direction if the opposite surface area is moving, then it is definitely, you can label it that abnormal sliding sign, and that you can confirm the diagnosis of that your uterus is adherent into the pouch of Douglas, and it is very difficult to separate it from the surrounding tissue. Now, let me go to the next slide. Now, these are normal posterior vaginal wall fornix. So look at, this is the cervix. I hope you can see my cursor. So that's the external os and that's the internal os. And look at this particular white area, which is an intact posterior vaginal fornix. And that white echogenic area, if it is breached, or you see a presence of hypoechoic areas in between this line, and if you don't see a regular kind of white line, then probably there is an involvement of posterior vaginal wall by endometriosis. So if I run this video a little ahead, you will be able to understand the curve of vaginal fornix or vaginal mucosa, and you have to see the relation of the draw the line in the line of internal os, and see the relation of that posterior fornix reaching this echogenic line up to that line of level of internal os. Okay, now in this you can notice that good transvaginal ultrasound, this is a lesion where I'm pointing out, that's the endometriotic nodule right behind the posterior fornix, and you don't see that white line intact there. You can see some hypoechoic blood collection baths there, or the lakes are there, which gives you very clear idea. So even simple ultrasound with a good machine is going to help you to even detect those small lesions which are present into the pouch of Douglas or posterior vaginal wall. For that, I think you need a good machine, good resolution machine, and also little magnified view, and a very strong suspicion of presence of lesions in these areas will help you to not to miss this presence of lesions. I think it's the same video. Okay, this is very important picture which I wanted to show you, because this is how on ultrasound you will see. Now look at this. This is the posterior vaginal wall. That's the fluid in the pouch of Douglas. But if you look at, see immediately the first layer, which is hyperechoic, that is the serosa of the rectum, and that will always be below that serosa. You will see two black hypoechoic areas and a white line in between, and that is the muscularis of rectum wall. So remember, this muscularis is the one area where you will commonly see in a DIE cases where the endometriosis has gone deeper into this muscularis layer, and you will not see this typical pattern like an endometrium. I always say triple line, triple line pattern of endometrium. It is almost similar. There are three white lines and there are two hypoechoic areas. So when you see a loss of this three white line layer of muscularis, that's probably a lesion present there, which is diagnostic of particularly. Then you have a submucosa, which is kind of a very thicker hypoechoic area, and then between two mucosa you have another hyperechoic line which is in the midline. So that is your mucosal surface. So as you can see in this smaller picture, look at that loss of a triple line pattern of muscularis, and you see a hypoechoic area where you have a severely hypoechoic cystic even region and thick muscularis wall of the rectum, and like a core, as you can see in the picture. So you can easily pick up these kind of nodules. This is a bowel nodule, actually, I mean the rectal nodule, which you can easily pick up by characteristic of thick muscularis layer. Majority times, rarely you see that the endometrium is involved mucosa and really embedded and has crossed the mucosa. So generally you will see that mucosa is very much intact over the lesion, and ultrasound can really help us to find out this kind of lesions. Now for bladder endometriosis, as you can see, you have to just gently do a transvaginal scan in a sideways, and you can notice these kind of lesions which are like a papillary lesions into the bladder lumen, as you can see there. So you cannot miss this diagnosis of bladder deep endometriosis. So with this, I'll start with my management of endometriosis. So goals of therapy. So when we have completely diagnosed the patient of endometriosis and also she is infertility, there are three important goals of our treatment. The one important goal is to preserve fertility. So very important. It's like suppose you have severe endometriosis and you have bilateral endometrioma. See, suppose you go on doing a cyst wall excision for bilateral endometrioma. How do we preserve that fertility? In fact, we are going to reduce that ovarian reserve because by operating on those. So understand that by doing surgery, we have to keep it in mind that we want to preserve her fertility, not reduce her fertility. And of course, to improve fertility, I mean to say by excising the disease properly without damaging the surrounding tissue. Also, if the patients have a gynecological symptoms like severe pain, then of course the pain has to be reduced. We have to consider this symptom in mind when it comes to a treatment strategy for management of endometriosis. And the most important goal I always feel is to delay the recurrence for as long as possible, because it's a disease which is very high chances that recurrence is possible. And that's why I divide these surgeries into two types surgery: fertility preserving surgery and fertility enhancing surgery. So both are very different way. Now we'll understand the treatment of endometriosis in infertility patients, but keeping aim in our mind to improve spontaneous conception rate, where we need not do any RT procedure, but we do some treatment by which she conceives spontaneously. And of course, there are no other factors for which ART is needed. So only three indications which I feel practically it is possible that you must do a laparoscopic surgery in endometriosis, because it does improve chances of spontaneous pregnancy. And that is into grade 1 and grade 2 endometriosis, where when you operate, you remove the disease and you have really good chances, but in the absence of any other infertility cause, okay, like semen factor, tubal factor, other cause. And the third very important, very encouraging results are seen in a unilateral isolated endometrioma, where you don't have a peritoneal disease, you just have a single unilateral endometrioma, maybe 3 or 4 or more than that. But that's a surgery which is very, very rewarding, because you have another ovary which is normal. You operate on one ovary, but the reserve doesn't go down because other ovary is normal. By removing disease, you improve her chances of spontaneous pregnancy because other factors are absent. So these are the three areas where laparoscopic surgery, I feel, in terms of improving the spontaneous pregnancy rate, is really, really, really helpful. About surgical treatment. Now, suppose you have done 3 IUI cycles for any patient and they have failed, and you have posted her for finding a kind of a reason for failure and done a laparoscopy. And when you see such kind of stage 1 and stage 2 disease, please go ahead and operate by laparoscopically. You do excision rather than just doing ablation. Wherever possible, excision should be the first choice. Where it is not possible, ablation should be the first choice. And of course, the adagio lysis. But do that job in the same sitting rather than just performing diagnostic laparoscopy, because it really increases the ongoing pregnancy rate. When what should be utilized, monopolar electrocoagulation is better, or a CO2 laser, but it is documented that CO2 laser vaporization is much better in terms of higher cumulative spontaneous pregnancy rate instead of using a monopolar electrocoagulation. Now this is the typical video. I hope you can see this video properly, but this is how the excision of implants are. This is very minimal disease. I do see some there in the behind the uterosacral. Then this is a lesion. So just go below below the lesion and excise at one particular plane where the normal healthy peritoneum is seen, and you remove that disease completely. Just lift the lesion properly. Many times, if it is a little larger in lesion, it's better that you inject the saline in subperitoneal region, and you will be able to remove that disease intact without damaging the underlying structure. So this is a simple technique of excision. Or you can use a kind of a fulguration. Sorry, I'll go back here. Yeah. So as you can see in this video that how to do a fulguration. So simply it is a kind of a little cicatrization, very difficult to lift it up. So just go and with a bipolar electrocauterization, just burn that lesion. Here you do see some kind of infiltration because there is a puckering present into this lesion. So try and do a maximum electrofulguration. Now, if it is a endometrioma, unilateral ovarian endometrioma, then instead of drainage and electrocoagulation, go for excision of endometrioma capsule. Now, when I'm talking about excision, I'm only talking about isolated proper endometriotic cyst. Now, there are two important differentiation we have to do. What is endometrioma and what is extra-ovarian endometrioma? So endometrioma is typically surrounded by all from all the sides a normal ovarian tissue, but extra-ovarian endometriosis is a collection of menstrual blood or collection of blood between the ovary and the surrounding structural surface like uterine surface or maybe peritoneal surface, where it is an extra-ovarian endometrioma, and because of the adhesions, the blood collection is in outside the ovary, not inside. So here it's not that the lesion is surrounded from all the sides by normal ovarian tissue. And remember, you must counsel such patients regarding the risk of reduced ovarian function after surgery and possible loss of the ovary. So because you never know, but at the expert's hand, it's always better that you do a best job, as I said, fertility preserving surgery and proper skillful surgical workup of during the first endometrial surgery is the most important. I think by this time everybody is aware about this, and repeat surgery that is for recurrent endometriosis should be avoided and should be carefully considered unless and until there is a real indication. Now, clinicians may consider operative laparoscopy for the treatment of endometrioma associated infertility, as it may increase their chance of natural pregnancy. So remember, okay, if it is a single unilateral endometrioma, you're allowed to do a laparoscopy. Okay, so that is a clear-cut indication. I need not show you how the endometrioma or cyst wall is excised, but typically in such patient where you have a unilateral endometrioma, you separate the endometriotic lesion or rather ovary from the peritoneal surface and remove that cyst wall completely from the surrounding structure. Now look at that particular steps. We are stabilizing the cyst wall and we are pulling the normal ovarian tissue. That is very important because that actually helps us to prevent lot of normal ovarian tissue loss. So steady the cyst wall and dissect or pull the normal ovarian tissue, and that's how you are gonna it will be helpful to preserve the ovarian surface. Now this is what I was talking. As you can see in the extra ovarian endometrioma, as you can see clearly that there is a blood collection between the ovarian surface and between the uterine wall, and this is typically extra ovarian. There is a false capsule, so you cannot remove any capsule. There is no capsule. It is only kind of a ragged fibrotic area, so you will not be able to have a clear-cut plane in between the normal tissue and the cyst wall. It's important in this scenario that you drain that fluid, expose the area, do a adhesiolysis, and cauterize the exposed surfaces, especially the peritoneal surfaces, not the ovarian surfaces. So there is not much loss of ovarian tissue during this kind of procedures because we are not doing any adhesiolysis or cyst wall excision from the ovarian side. Now, if you look at a cycle-specific or cumulative fecundity in patients with endometriomas or endometriosis who are undergoing COH and IUI treatment cycle or IVF embryo transfer. So remember, in endometriosis, pregnancy rate per cycle fecundity rate and cumulative fecundity rate are significantly higher with IVF-ET than doing a ovulation induction with IUI, especially for stage 3 and 4 and women who are more than 38 years age. Remember, considering the adverse effects of prolonged ovarian stimulation on endometriosis, IVF-ET should be the first line approach because your one cycle you do a good ovarian stimulation, retrieve the number of oocytes and form the embryo and freeze the embryo or maybe transfer in a fresh transfer. If COHI is attempted, that it should not exceed 3 cycles because the pregnancy rates from the 4th cycle is very, very poor in endometriosis. So not more than 3 cycles, especially that is only for stage 1 and the stage 2 disease of endometriosis. Now, endometriotic cyst management. Now, yes. So we always question comes into our mind, does endometriotic cyst affects fertility? That's a big question for us. Does endometriotic cyst excision surgery improves fertility? whether benefits of endometriotic cyst excision outweighs the risk associated with surgery. And fourth, what are the complications of surgery? So remember that endometriotic ovarian cysts are mostly thought to occur through invagination of endometriotic tissue or cells through the ovarian serosa during remodeling of ovarian cortex after ovulation. And the presence of ovarian endometrioma is usually associated with moderate to severe disease. So you have abnormal altered follicular environment, and it is represented by elevated, you will see elevated concentration of progesterone, interleukin 6, and decreased concentration of VEGF. That is all responsible for alteration within the oocytes, leading to impaired fertilization capacity of the oocytes and reduced embryo quality with low implantation potential. So endometrioma through its inflammatory reaction reduces the oocyte quality and also its fertilization potential. If it is bilateral endometrioma, then it can affect the ovarian significantly if you decide to operate on both the ovaries. So follicle depletion may be secondary to the damage induced by the endometriosis associated inflammatory reaction and by increased tissue oxidative stress leading to fibrosis. So a lot of times we do see that the side where the endometrioma is present, you see a lower antral follicular count because it does causes oxidative stress damage, tissue damage, and also endometriosis related inflammatory reaction causes damage to the surrounding normal tissue. And a free ion that can actually diffuse through the cyst wall of endometrioma, because we know endometrioma is a old collected blood. So there is a free ion which slips into the ovarian tissue, and that can have a detrimental impact on the ovarian reserve. Now, is there any critical endometriosis ovarian responsiveness in ART techniques? So significantly lower number of follicles which are more than 16 millimeter and also number of oocytes retrieved in the ovaries containing endometrioma were observed. So we know, and evidence has shown us, that the side where endometrioma is present, we will always have a lesser number of oocytes in comparison with a side where we don't have endometriomas. And they also seen, that was a previous guideline also, in fact, in patients with endometriomas more than 3 centimeter, size was the most influential contributor to the total number of follicles and the oocyte retrieved. And that's why previous guidelines used to always say that anything more than 3 centimeter, and if a patient is going for ART, you remove the endometrioma or operate on endometrioma. Now, what happens if it is endometrioma is less than 3 centimeter? So the number of oocytes retrieved from the ovaries with endometrioma, from the ovary where endometrioma is present, the number of oocytes retrieved and the contralateral normal ovaries were comparable. And that's why endometrioma less than 3 centimeter per se did not have a deleterious effect on ovarian reserve in ICSI cycles. But whenever you operate, this clear-cut systematic review has clearly shown that there is definitely significant reduction of serum AMH levels after surgery. Reduction in the ovarian reserve is a big one. As we can see in bilateral endometriomas, as in this study, where group 1 actually previously undergone bilateral endometrioma cystectomy, and they are selected for IVF FOGSI cycle. And second group included 136 patients who did not undergo prior ovarian surgery. So women who are operated on for bilateral endometrioma had a higher cancellation rate because of the poor response. So obviously, because both the ovaries are operated, reserve is significantly reduced. So because ovary also responds poorly to the ovarian stimulation, you will always see the number of follicles, oocyte retrieved, embryos obtained, they were all significantly lower in group 1 where the surgery has been done. And if you look at the outcome like clinical pregnancy rate or delivery rate, they are all significantly less when the surgery has been done. So, a lot of controversy initially whether to operate bilateral, but it is very clear after this study that bilateral endometrioma do not operate because first preserve the fertility, and that's very important. Now, surgery prior to ART in different stages of endometriosis means we know that we are doing ART for any other purpose, like for maybe tubal factor, maybe for sperm factor, or maybe even peritoneal factor. ART is sure that we are doing, but she also has a endometriosis. So what surgery we should do prior to? Now, these guidelines have significantly changed. Now, clinicians for grade 1 or grade 2 endometriosis are not recommended to do routinely the surgery for endometriosis prior to ART. So Even somebody has done the laparoscopy and you have diagnosed grade 1 and grade 2 disease, and that surgeon has not operated, and you are going to take this patient for endometriosis, there is no need to do a repeat laparoscopy just to tackle that disease. That's very important. And also applies same for ovarian endometrioma, that clinicians are not recommended to routinely perform surgery. These are 2022 recent guidelines. The evidence which I showed you in previous slides was the older guidelines. But now we know that if you don't operate, it doesn't, if you operate, it doesn't improve live birth rate. So there is no improvement into live birth rate. So why to operate on ovarian endometrioma? So we don't find any benefit, and surgery is in fact likely going to have a negative impact on ovarian reserve. And that's why we only should be only we should consider surgery for endometrioma if we have to improve endometriosis associated pain, or there is the accessibility of the follicles. We'll see those indications. What about DIE? Again, the decision to offer surgical excision of deep endometriosis lesions prior to ART should be guided only mainly by pain symptoms and patient preference, as its effectiveness on reproductive outcome is absolutely uncertain due to lack of randomized studies. So we don't know till today. But yes, if the patient is feel that her quality of life is really hampered and her pain symptom is too severe, it's fine to operate. But in terms of ART outcome improvement, probably no role of surgery. So these are very important tips and very important points. Where should we do do a surgery? So when you want to do a surgery for endometriosis, you must consider age of the woman. You must consider her ovarian reserve status before surgery. You should see a unilateral or bilaterality of the disease, number and the size of the cyst, symptoms. Like, as I said, for pelvic pain, you will operate. Presence or absence of suspicious radiological features, which suggest to you that there's a possibility of malignancy in the endometriotic lesions, and extent of extravagant disease and history of previous ovarian surgery. All these factors should be considered before you decide whether I'm going to operate on this patient or not. So when we will operate in severe endometriosis before ART, when pain is so severe which is not controlled efficiently by medical treatment, we'll operate in infertility patient when ovaries are not approachable for oocyte transfer. So we operate to mobilize ovaries into the normal position so that we can retrieve oocytes. When we have associated hydrosalpinx before ART, and we know that hydrosalpinx is associated with a significant reduction in the clinical pregnancy rate. So remove or salpingectomy or proximal tubal occlusion is something what we are looking at while doing the surgery on such kind of scenario. Or patient is not ready to undergo ART, but wants to have, for whatever purpose, maybe social, financial, ethical. So there you can improve her chances of spontaneous pregnancy without ART if you do a surgery. So these are the few indications which I feel that we must operate. And what about role of post-operative GnRH agonist treatment? So women seeking pregnancy should not be prescribed post-operative hormone suppression with the sole purpose to enhance future pregnancy rate. So giving that post-operative hormone suppression is not helping us, because this is an infertility patient. So those women who cannot attempt to or decide not to conceive immediately after surgery should be offered only this kind of post-operative suppression with GnRH agonist depot, as it does not negatively impact their fertility, but improves immediate outcome of the surgery for pain. So with this, just few points about ART in endometriosis. Now, we used to practice like this on using our brain, hands, everything, but we want to be smart enough, just use ART and do a job for what purpose she is there with you. So like IUI or IVF. So in this group of patients, where it was 2002, very old study, but very beautiful study, where endometriosis stage 1 and 2 was compared with endometriosis 3 and 4, and IUI was done. And there was a significant difference in pregnancy rate when it comes to stage 1 and 2 to stage 3 and 4. So IUI, controlled ovarian stimulation with IUI, should be limited to stage 1 and 2 disease, which we have understood the type of the disease. Again, just don't do ovulation induction, do IUI. That's very important. But when it comes to severe disease, I think we have to understand that endometriosis fertility index is something is going to help us. But again, it's a big classification, big, index, lot of things to assess. we really have to sit on the table and do the paperwork, and really it's very difficult practically. But it has been seen that if you really take efforts to find out this endometriosis fertility index, it's a novel index for predicting the pregnancy after surgery. And not only that, it's going to help you to decide whether I should advise this patient to undergo IVF or no. So it has been documented in a couple of these studies which are done recently. This is 2017, which says that if the if you look at the option 2, that is 4 to 6 months non-ART followed by ART, means you have a patient who's got a this fertility index less than 4. So we have given that option of ART, but having an index between 5 to 6 or 4 to 6, so we have given them 4 to 6 months non-ART treatment, that is maybe spontaneous trial or maybe COH with IUI. And if she doesn't conceive, then ART. If the endometriosis fertility index is more than 7, then directly 6 to 9 months she will try with ovulation induction and IUI. So what they found that the mean time to conceive for non-ART pregnancies was 4.2 months. On multivariate analysis, the index score more than 5 was significantly associated with non-ART pregnancy. Below 4, I think we can advise this patient to undergo IVF. Now, similarly, it is documented is in 2021 also that the ART conceptions are more higher significantly when the index is less than 4 and in comparison with index more than 5. So ART can be performed for endometriosis associated with or infertility associated with endometriosis, especially if the tubal function is compromised or there is an associated male factor infertility in case of low endometriosis fertility index, or if there are other treatments have failed. But remember that women who with endometriosis can be reassured that say if you undergo ART, the recurrence rate are not going to increase. Okay, and not only that, we must take care of endometrioma. When the presence of intact endometrioma, we must give a good antibiotic prophylaxis at the time of oocyte retrieval. We have recently seen post pickup patient do come after 6 months, 1 year later, that they do come with a pelvic abscesses. So good antibiotic prophylaxis is really must, because any intervention which is going to be from vagina for oocyte retrieval gonna high chances to carry a bacteria from vagina and colonize the ovarian surface or ovarian tissue and cause a pelvic abscess or ovarian abscess. And that's why it is very important. So what we do in such patients even before oocyte retrieval, we give a good betadine wash to vagina. Then we wash this betadine with properly with a normal saline, and then we go ahead. So you get nice antisepsis in vaginal surface. It has been shown that COH and IUI intervention significantly increase the likelihood of pregnancy relative to that in the follow-up group during the 1 year study period. So this is, I'm talking about endometriosis following surgery, treatment of endometriosis following surgery. The clinical pregnancy rate was significantly higher among those where stage 1 and 2 disease is present than moderate to severe disease. So only for stage 1, stage 2, IUI, stage 3, stage 4, you can ask for IVF rather than IUI. Now, what to do about once you do the surgery or you have diagnosed? Shall we do a post-operative or GnRH agonist suppression, prolonged suppression prior to IVF? Because there were papers where they said that if you give a 3 to 6 months prior to IVF GnRH agonist, then it increases the odds of clinical pregnancy by 4-fold. Like this, you have given 2 to 3 GnRH agonist depot, and every 28 days you repeat. So after your third injection or second injection, anytime you can start the ovarian stimulation. You don't need any other strategy for down regulation. You just keep on giving gonadotropins. Just need little more duration for ovarian stimulation and more doses of gonadotropins, but it gives you much better. But then last 5 years reports, they clearly said that these kind of extended administration of agonists prior to ART treatment, they are not helping to improve the live birth rate. So it is not recommended anymore. So directly, as you have diagnosed and you have decided for ART, then go ahead with GnRH antagonist or even agonist protocol, that is long day 21 protocol, can be offered because there is no difference in pregnancy and live birth rate. So, so this is what I have to say. Coming to the conclusion, I'm coming just a few minutes, last couple of slides, that a decision to proceed with surgery for endometrioma should be carefully considered. Those all points which we discussed: consider the age, ovarian reserve status, see for unilateral bilaterality of the disease, size of the cyst, symptoms, presence or absence of suspicious features on radiology, extent of endometriosis disease, history of previous surgery, and surgery may be considered first line in highly symptomatic women, those with an intact ovarian reserve or unilateral and a larger cyst, and should be considered for cysts with a suspicious radiological and clinical features. And instead of chocolate cyst excision, IVF with embryo freezing followed by frozen embryo transfer in a downregulated cycle gives a similar pregnancy rate. So rather than doing a surgery, better to go for IVF with embryo freezing and followed by frozen embryo transfer. So friends, never stop doing our best just because someone doesn't understand it. We need to do our best for our own satisfaction, not for others' application. And that's the sentence which I always carry in my presentation, because this is what we are as a clinicians for our patients and for our own self, that we are purely clinicians. We are not evidence guided people, but our own experience, our own understanding of the disease is going to help us to manage these patients very properly. Instead of, as I said, instead of doing any damage to fertility, preserve the fertility and at the same time deliver that fertility with the help of ART instead of doing any invasive surgery on these patients. So thank you very much for this patient hearing, and thank you very much Jagsonpal team for giving me this chance to present my views regarding endometriosis and infertility. Thank you very much, and over to you, Chairperson, for your comments.
Dr. Kundan, it was a lovely talk. You have put across beautifully so many lovely points. That laparoscopy is not the gold standard for diagnosis anymore. And we can do a wonderful diagnosis with the IDEA group of consensus. You can even find out what type of disease you're dealing with. Is it stage 1, 2, 3? Because you can see the sliding sign, tenderness, adhesions. So these help you to diagnose whether the disease is advanced disease or mild disease. So you need not do laparoscopy for everyone. Gone are the days, because many of us grew with the days of laparoscopy when ultrasound was not available. I would say in 1977, when we started diagnostic laparoscopy in Coimbatore, ultrasound was not available at all. So we all grew up with the laparoscopy. But today, in the days of high resolution ultrasound, we have to utilize this more and more and forget about doing multiple surgeries on young women. We have seen women who are married for 5 years with 3 laparoscopies, 2 laparotomies, exhaustion of the ovary, then going for adoption, hysterectomy, etc. So it's very important for us to spread awareness among our colleagues and also the community about early diagnosis and the need to avoid multiple surgeries on these women. And you also said very nicely when to do surgery and not to do surgery, the importance of endometriosis fertility index. And if it is unilateral, you can do surgery, but if it's bilateral, then the loss of ovarian reserve would be very high. So we have to avoid surgery. And I have one question for you. If it is a patient with poor AMH and bilateral endometrioma, married for 4 or 5 years, comes to you, would you like to do an excision or fulguration? Her AMH is 0.5. This is a pathologist I've seen last week.
Yeah.
I think she's about 34 years and married 5 years. Never tried for a pregnancy because she was studying. Now that she finished the pathology MD, she says, okay, I want a baby. And she has grade 4 disease.
Yeah, I think you are saying that she has a bilateral endometrioma also.
Yes, yes.
Yeah. I think she's 34 years old, though she might have a very low antral follicular count because AMH is 0.5, as you said. So whatever, that age is little advantage for her. So I always feel that if you operate on her, it's going to reduce further that reserve. So do not operate. That's the first thing. And stimulate her, retrieve the oocytes, try and get those oocytes.
Would you like to take her up for antagonist or agonist site?
I will
long agonist or antagonist?
Yes, I will directly go for antagonist protocol for her, because little advantage of antagonist protocol is that initial follicular suppression is not there, hormonal suppression. So
yeah, exactly. Yeah.
Of it. And now evidence is very clear that You do agonist long protocol or antagonist, there is not much difference in terms of, ovarian response. So you will still get the similar. Now, only in case if you have a kind of a very asynchronous growth on your first IVF stimulation, ovarian stimulation on antagonist protocol, then probably you can think of when you go for second stimulation, if you have abandoned that cycle and because of asynchrony. So if you want synchronous growth, only there day 21 long GnRH agonist protocol will really help. But I will not operate on this patient till I have a good embryo in my hand, because
and she's a pathologist. So we did all counseling, all consents, and we'll be going for a pickup shortly with the antagonist cycle.
yes,
And then let us see whether we are able to get any follicle, because I do not see any follicles.
yeah,
around.
her chances are little low because AMH is absolutely borderline, because with this patient who's got AMH of 0.5, maybe she's got only 20-30% chance to get a good blastocyst.
I asked her, would you like to come without your husband and mother-in-law and talk more in detail, because she's a pathologist. She said, no, she's being very, let them also come, let them know about my disease, no problem. So that's a very nice doctor she is. So it was a fantastic talk. We enjoyed very much. A lot of lovely points brought out. And thank you, Kundan. And thanks to Jagsonpal, Dr. Deepika Chopra, for having given us this opportunity to carry on with this discussion. Thank you.
Sure.
Thank
Dr.
you very
Sumita,
much,
your
ma'am.
points of view.
Thank you, Dr. Ingale. Very good talk, and you have elaborated very nicely when to do laparoscopy, when to go for ART. I have one question for you. Suppose you get an unmarried girl, about 24 years old, with AMH between around 1, and she has bilateral endometrioma. How would you approach this patient?
Okay,
This is a common syndrome.
if a patient is young and probably you think that this patient may not have, plans to have an immediate in next few years marriage, then probably fertility preservation can be advised, number one. But I always feel that instead of doing any fertility preservation, here probably medical management is going to help a lot in these kind of patients, because you have some time before she needs to think of her reproduction, because a medical management with the help of Dienogest molecule, this is the only molecule which will help you to resolve the disease completely. If you give it for prolonged time, like minimum for 1.5 to 2 years, then you will really see those things that where this endometriomas has completely collapsed, disappeared, and even the disease burden has reduced significantly. So Dienogest has been documented to reduce 30% of the endometriosis completely. Okay, completely. It gets abolished. So in such patient, we will counsel for fertility preservation to this, but at the same time I will counsel her for being on Dienogest for a prolonged time, 2 to 3 years, so that we reduce her disease burden. And whenever she is planning for a reproduction or marriage, then do not waste much time, assess the ovarian reserve that time, and proceed for IVF with embryo freezing. I think that should be ideal way in handling such patients. Or if they require fertility preservation, with her consent, we can actually do it even if she's not married. But this is what options we can give it to such patients.
So is there some cutoff size for the cyst where you will consider medical treatment? Is there some cyst size you will consider?
No, I don't think so, because finally it's not the size. The Dienogest is going to act on the endometriotic implants from where she's having this kind of source of bleeding, which is getting collected into those cysts. So we are looking at, even I have seen and we have done Dienogest therapy for patients who's got 6 to 7 centimeter endometriomas, and after 2 years we have seen that they have reduced it to 1 or 2 centimeter only. Okay, and really the disease burden goes very significantly down. Even one patient we had where we gave it for 4 centimeter endometrioma 1.5 years. Then she wanted to plan a pregnancy. So it's been almost 3 years now. We haven't seen the recurrence of that endometrioma again. With that kind of resolution does happen with Dienogest. So whenever you have time where fertility is not immediate need, I think medical line of treatment plays a very important role.
That's a very important
kind of fertility.
What about liver function test? Should we keep getting, as you're giving progesterone for such a long time? Any role of getting liver function tests done? Is it needed?
In fact, Dienogest do not have a adverse effect on liver function test. Even if you give it for, even literature has given 5 years documentation. But
Okay.
we have an experience of using Dienogest for 2.5 years for multiple patients. Okay. And it has been very clear that Dienogest do not have an impact on the liver function test. So no, quite a safe drug actually to use it for a longer time.
That's excellent. We'll just look at the question answer if there are any questions. Deepika?
Yes, ma'am.
There are
In
few
the
questions, they are not there.
there is one
This is
question
one-
in the chat box also, ma'am.
Yeah, yes. This hormone replacement therapy after hysterectomy with bilateral salpingo-oophorectomy for severe endometriosis. Age of the patient 38 years. So what is your...
Probably we can think of, if we have done a BSO, she needs hormone replacement therapy. But that decision of HRT, I think I will also consider that what kind of surgical workup we have done. I mean, we have done the hysterectomy, we have done the BSO. I agree. But these patients may have a endometriotic implants, microscopic. If we have not taken care, there is a chance of recurrence when you give HRT. Because we here 38 years, we are going to give her HRT for at least 10 years. Okay, so I feel, but yes, majority times during such kind of procedure, the workup is done nicely. So after BSO, she is going to have a surgical menopause and menopausal symptoms. So I think HRT should be given in such patient, and giving HRT will not improve or increase her or fasten her recurrence rate also. So HRT should be given. That is very important.
Okay. Now there's another question, current stand of Dienogest. I think you have already answered that. And Dr. Purnima is asking, in case of grade 1 and grade 2 endometriosis, can we go ahead with COH, IUI first without surgery?
Yes, in fact, it is recommended that you need not tackle that disease before IUI. So you have a good and sufficient, I mean, better pregnancy rates without doing any kind of ablation. So it is not required. If you suspect grade 1 and grade 2 disease, you can definitely go. Only thing is that just do a 3 cycles. If the patient do not conceive in 3 cycles, then only you can think of doing a surgery to find out any other cause of failure of that treatment.
Okay, I think very commonly we find pelvic tuberculosis also associated with endometriosis.
Yeah, actually, we do see that there is a common association between pelvic tuberculosis and endometriosis. We don't have a scientific backup for this association, but probably it is the lower immunity available in, lower immunity in this pelvic peritoneum makes them prone for, tuberculosis to flare up. That is what is probably, because many times we have a latent tuberculosis, which gets dormant tuberculosis gets active if you have a lower immunity. So those abnormal cytokines are responsible for it in the pelvic area, and that's why we do see a common association. But it's per se, endometriosis will not cause tuberculosis.
Well answered. I think any other questions, Deepika? I think we are done with the question answers.
Ma'am, there are many questions which are now coming up. If you, because the time is over, if you permit, can we ask a few more questions? There was one question by Dr. Bashir Hussain. He's saying, may I send any patient I did resection of endometrial tissue or not need histopathology?
I did resection of endometrial tissue or not.
I think the same question he has put in the chat also. If I do resection in endometriosis, may I send histopathology?
Oh yeah. Yes, ideally, when you have a tissue, histopathological diagnosis is, important for all medical legal purposes. So it's good to send the specimen for histopathology, because it's going to just give. But let me tell you, the problem with histopathology, typically those small implants, when you send them, they will always tell you that they are just the inflammatory complex or glandular inflammatory complex. Pathologists, they do not report that it is endometrial tissue. And that is the only problem in India from pathologist side. They don't report endometriosis. And that's why we have to give a background history to the pathologist, because that's how they will think of, giving that endometriosis diagnosis.
Then there's asking questions about what HRT would you recommend after the BSO hysterectomy in young women? Matlab combined or only estrogen?
Okay, because it is already uterus is absent. So it is only the estrogen is what is indicated, not combined. It is only estrogen to be given.
And they've asked how long Dienogest can be given, which I think you have already answered.
Yeah, it's almost even documented for that. We can give it even for 5 years in the literature.
And how much dose? How much dose they are asking?
IPOS study
It is 2
by the
milligrams per
Visan
day.
group.
Yeah, it is 2 milligram per day, and always you start from second day of the menses, and ask patient not to interrupt the therapy. Give it continuously. Now there was question I saw that can we give a break in between the Dienogest? So if you really want a good result of medical therapy, don't give any break for the therapies. So you give it continuously. You achieve that continuous, because Dienogest achieves the very lowest levels of serum estrogen concentration. If you compare with any other drugs, even with GnRH agonist, Dienogest is associated with the lowest serum estrogen concentrations. And that's why if you maintain that concentration, you will not get any recurrence. You will get a perfect, and that's why the complete resolution disease percentage is higher with Dienogest. Don't give any interruption.
Yes,
There's a
there is a small
question.
dispute here, Dr. Kundan. There is a small dispute. That is, with JNRH, you get a level of less than 30 picograms. So there is a bone loss. Whereas with Dienogest, you get a level of 30 to 50. So there is suppression of lesion, but no bone loss. So the
Yeah.
lowest levels are reached with JNRH agonist and not with Dienogest.
Now,
Dienogest, the advantage it maintains between 40 to 60, which is okay, and there is no bone loss.
okay, there is, I do agree with you. Both levels of 30, 50 or 40 will give us a good suppression. But I remember there was one study which has compared agonist with Dienogest, and they have documented that the serum estrogen average levels have really gone down with Dienogest to almost to 26. And that's why
So then you get a
that one
bone
study.
loss, if it goes so low, it will get a bone loss.
Now,
Less than
even
30 with
the same study-
JNRH causes a bone loss.
even
And
the
with
same
Dienogest,
study-
it is 40 to 60.
This mid-luteal.
Yeah. So the same study has documented that when you start Dienogest, you will see a little bone loss in the first 6 months. Okay. But that if you continuously give Dienogest, this particular bone loss is, achieve the steady levels. It is not a progressive bone loss. You will do see, and that's what it is mentioned in the same study, that it's not that it just does not affect. It definitely affects the bone. I mean, reduces the bone loss. I mean, reduces the bone density. And but it is goes little down and steady there. So it doesn't like that a continuous administration is going to lose a bone over the time period. So it's not a progressive bone loss.
Are there time for more questions? There are a few more. About the role of cabergoline in stage 1 and 2 endometriosis. Anyone?
I don't think so that probably cabergoline is improving the results. Rather, I feel that for stage 1 and stage 2 disease, there is no need to add cabergoline. But go ahead with ovulation induction and IUI, because typically in these patients, typically in these patients, your tubo-ovarian relation is maintained well, and you do not have a ovarian involvement, so you have a better oocyte quality. Of course, there are conflicting papers. There were papers who said that in the presence of minimal to mild disease, the IUI pregnancy rate goes down. Okay, but over the time period now, with the systematic reviews, it has been very clear that it does not affect significantly reduction in the pregnancy rate. So probably there is no need, I feel, and that's the evidence that addition of cabergoline is going to improve dramatically the result, unless and until it is only if there are high prolactin levels.
Thank you, doctor. Very nicely you have answered all the questions. There's one more about, is Dienogest effective for adenomyosis?
Yes, it is definitely effective, because it acts at the endometrium at abnormal site. But only thing is probably what we have seen with adenomyosis, with effect of Dienogest on adenomyosis, we don't see a reduction into the uterine size. See, here in endometriomas, we do see a reduction in the size. Here, in fact, we see a lot of fibrous tissue deposition with overuse of Dienogest in adenomyosis. So any fibrous tissue deposition in the myometrium will interfere the endometrial blood flow. So probably in terms of fertility point of view, when there is a desire of future fertility, Dienogest for adenomyosis is little have a kind of a dual role. Not very sure that it is so effective. Symptomatically, it will get controlled very well. Yeah. Dr. Asha, you have to unmute yourself. Yeah.
Set.
Yeah, I've done that, ma'am.
Yes, Dr. Asha.
Yeah, have been unmuted.
Yeah,
Yes,
yeah.
ma'am.
Okay. So there is a beautiful paper by Matsushima et al. Where they made a study for 16 weeks. Use of Dienogest versus low dose estrogen progesterone versus GnRH analog. The use of GnRH analog, they observed a drop in the uterine volume by almost 50%. Whereas with low dose estrogen progesterone or Dienogest, there was no significant loss of uterine volume.
Yeah.
So for uterine volume reduction, GnRH is much better than Dienogest.
Yes. I agree with that point.
Yeah, thank you.
Excellent talk. I think we are done with all the questions and we can proceed with the next part. Over to the organizers.
Yeah, thank you all. Thank you, the experts. And it has been such an interesting webinar that the questions keep on coming up, and I don't think we could solve all the queries even if we sat for another 1 hour. So we have to abide by the timings also, as we have taken a lot of time of the experts and the attendees. So it is already 7 past. Although we have planned a quiz on endometriosis, where the attendees could try their luck also, because it is the fastest finger first quiz. So first we'll take on the vote of thanks and address by our sales team person, Mr. Om Prakash, who is our zonal sales manager. And after that, we will request those attendees who are interested to play the quiz, they can stay back, and we will then close this webinar. So thanks a lot to Dr. Kundan Ingale, Dr. Asha Rao, and Dr. Sumita Verma, ma'am, for taking out so much of your time and giving us such a knowledgeful webinar, which has, I am sure, benefited everybody, and the recording will remain available on Facebook. Apart from that, we will also put it up on YouTube, which will be an edited version. So that link will come up later, but the YouTube channel name is Jagsonpal Medical Insights. So you can always subscribe to that and an alert will reach you then. Thank you all very much. And now over to my teammate, Mr. Om Sharma.
Thank you, ma'am. Good evening to all respected doctor. I am Om Prakash Sharma, Zonal Manager West Zone. Bring greeting from NAARI Division of Jagsonpal Pharma. We thank you for this opportunity to connect with you all today through this webinar and are proud to present EndoReg 2 mg tablet. Doctor and suspected and confirmed case of endometriosis presenting the brand of EndoReg. Each tablet of EndoReg contains Dienogest 2 mg tablet. Dr. EndoReg offers the endometriosis regression at its best. Doctor, as per the latest reference, the patient having history of severe and primary dysmenorrhea, 73% confirmed with endometriosis. Doctor, in case of clinical suspected endometriosis with Dienogest in EndoReg, 81% patient responded with reduction in endometriosis associated pelvic pain. Doctor, at week 52 of Dienogest therapy, 74% patient having dysmenorrhea score of 0. Doctor, Dienogest and EndoReg is safe and adolescent girl, safe and effective from the perspective of ovarian reserve. Doctor, EndoReg offers longest shelf life of Dienogest 36 months as compared to other brand 18 months. Doctor, EndoReg offers calendar therapy pack. Doctor, Dienogest and EndoReg prevent the post-operative endometrioma recurrence and significantly reduce pelvic pain and lesion size. Doctor, and post-Dienogest and EndoReg treatment improve the sexual function, improve the pain score, and improve quality of life. Dr. Dose of EndoReg is 1 tablet OD for a minimum of 3 months. SAP established for 5 years. Dr. EndoReg offers calendar therapy pack and minimize the chance of missed dose. So doctor, please prescribe EndoReg as EndoReg offers endometriosis regression at its best at the most economic cost. Thank you. Thank you, ma'am. And thanks my all respected doctor.
Thank you very much, Mr. Om. And now for the benefit of our attendees, please note down this webinar ID and register for our next webinar, which will be on medical legal issue, which is consent in daily practice. This is on Sunday. I'm sorry, it's written here Saturday. It is Sunday, 8:30 a.m. early morning for a 1-hour session. And the speaker is Dr. Tushar Roy in New Delhi. So thanks a lot for joining in today. And I'm sure that those who are interested would like to stay back for the quiz. And I thank the experts and the speaker today for being here with us, sir. Thank you.
Thank you, Dr. Deepika and Mr. Om. With your permission, I will leave. And
Thank you.
You can continue.
Thank you, sir.
Yeah, thank you.
Thank you, sir.
The quiz pin will be put up here in the chat box, and there will be a link which is coming in the chat box. After this, the quiz starts. It is a fastest finger first also, apart from being the best, the right answer. So the person who is fastest and correct will be the winner. So we start the quiz now. 25 people are going ahead with the quiz. Worldwide, how many individuals with uterus are living with endometriosis? You have to click on that color, whether it is 1 in 50, 1 in 10, 1 in 25, or 1 in 4. We have 25 people, 25 answers need to come up. Okay. 5 have the correct answer, and the winner is currently leading is Dr. Poonam. Many endo warriors also experience depression, allergies, anxiety, or panic disorders, or all of them. The pin is 6906572. We go to the third question. On average, how long does it take to be diagnosed with endometriosis? Less than a year, 1 to 5 years, 5 to 10 years, or 10 years or more? On an average, how long does it take to be diagnosed with endometriosis? Leading is still Dr. Poonam Gupta. Only adult women can experience endometriosis. Is it true or false? Only adult women can experience endometriosis. So mostly everybody knows that it is false. Dr. VG is now leading. Deep infiltrating endometriosis is a rare and uncommon form of endometriosis. True or false? Dr. VG still leading now. Dr. Yukti joining up. Endometriosis can reoccur even after surgery. True or false? Everybody knows that. Ethinyl estradiol and Dienogest is one of the reliable ovulation inhibitor with high contraceptive efficacy. Do you agree or no? Ethinyl estradiol and Dienogest combination pill agree. COCs are effective in treating endometriosis related symptoms. Do you agree or no? Mostly everyone is agreeing to that. So we have the podium now. At third position, we have Dr. Yukti. At second position, we have Dr. Jyotsna. And at the first position, we have Dr. VG. So now I would like you to please raise your hand so that we can unmute you and we can have a word with you. Okay. Introduce yourself.
Good evening, everyone. Can you hear
Congratulations
me?
to you.
Yeah. Hi, I'm Dr. Yukti Bhardwaj. I'm from Delhi and I'm currently doing FNB reproductive medicine in Sudha Hospital in Tamil Nadu. And thank you. It was a very interesting and informative quiz. Thanks a lot.
Somebody come and deliver your prize.
Thank you
Okay.
so much. Thank you.
Okay, thank you. Dr. Jyotsna, if we can have your hand, is that Dr. Jyotsna Pathak, who is the winner? Yeah,
Yes, ma'am. Good evening, ma'am.
good evening. Congratulations.
I am Dr. Jyotsna. I'm working as an assistant professor in the Department of Obs and Gynae in IGIMS. It is a government at Patna. It is a government medical college.
Okay. So your prize will be sent through our sales team. I hope they are visiting you currently also.
Thank you, ma'am. Thank you so much.
Yeah, and then we have Dr. VG. I cannot find who that is. If you can raise your hands, then we'll unmute. Is that Dr. Vaidyanathan Gauri? So thanks a lot for being here today. And after this exciting academic feast, we also enjoyed a little bit with the fun time together. And congratulations to all the participants who participated in the quiz. And of course, to the 3 winners, your prizes will be coming to you within this month, probably, which will be delivered by our sales team. So thank you all and good day.
Thank you. Thanks all doctors, and thank you, Deepika ma'am, also.